Our next talk is a rapid fire, Outcomes Following Mechanochemical Ablation of the Great and Small Saphenous Veins Based on Diameter, presented by Annabeth West from Emory, and the senior author is Jaime Benarroch-Gampel.
Tough to follow that lively of a conversation on Epic Chat. Thank you for the opportunity to present our work. We have no disclosures. Guidelines published jointly between the Society of Vascular Surgeons and the American Venous Forum recommend treatment of symptomatic axial reflux of the great and small saphenous veins, and further recommend that treatment be with an endovenous ablation over surgery. We know that larger vein diameters are associated with higher rates of recanalization after thermal ablation procedures. But with non-thermal techniques like mechanochemical ablation, or MOCA, gaining popularity for a variety of reasons, there's limited data regarding vein size and its association with outcomes for providers to use to guide their practice. For this study, we performed a chart review of patients who had undergone mechanochemical ablation, or MOCA, at our institution between 2017 and 2021. We divided treated veins into two cohorts, with the larger vein diameter cohort being with 1 or more centimeter in diameter. We conducted comparisons of post-op complications, as well as 2-year analysis of recanalization and reintervention. With respect to the cohorts, there was no difference in major comorbidities, age, gender, anticoagulation use, or importantly, treated vein segment length. Additionally, there was no difference between the cohorts with respect to prior DVT, prior venous intervention, but importantly, there was a higher incidence of C6 disease at presentation amongst those with the smaller vein size. Comparing the immediate peri-procedural morbidity, there was no difference in hematoma, nerve damage. Actually, we saw no nerve damage with this technique, there was a slightly higher incidence of postoperative pain or post-procedural pain with the larger vein diameter. At 2 years, there was no significant difference in symptom recurrence, recanalization, or reintervention between the two cohorts. And on Kaplan-Meier analysis, again, there was no difference in 2-year recanalization-free quote-unquote survival. In conclusion, vein size in our study was not associated with recanalization following MOCA, and thus this technique should be considered in those with larger vein sizes. Limitations are, obviously, this is a single institution study, so there is a relatively small study population size. And larger studies are needed in the future so that providers can be armed with data with respect to these newer technologies such as MOCA as they gain popularity in practice. Thank you.
As Misty's heading to the microphone, so is there an IFU here that applies, or is it open to all vein sizes, and you guys chose to look at more than less than 1 centimeter?
As far as the exact IFU, I'm not sure off the top of my head. I know that in the data about the device, that the maximum diameter is 6.5 millimeters, and so if you're using it on a vein size that's larger than that, then they recommend compression to collapse the vein as you're doing the MOCA so that the rotating wire can actually make contact with the endothelium. So we use about a 50%.
If Dr. Sheehan's nemesis is EPIC, mine is crazy acronyms that I am going to have to go through and talk about for MOCA forever. So I'm not quite familiar with this particular technique, and so perhaps you can explain it. And my question was actually about the same kind of line here. 1 centimeter doesn't seem like a big difference, and why not compare it to something like radiofrequency ablation or something along those lines, or glue, for that matter?
So as far as the device, the Clarivan is the one that's available in the U.S., and it's a rotating tip at the end. So the thought is that it causes some endothelial damage, disruption, as well as then you instill a sclerosing agent. Most people use STS, and so it's kind of a multimodal approach to vein occlusion. As far as why not compare, there are some studies that have compared the two. I don't know, I've seen Dr. Benarosh getting up to the, but we were trying to, I think, mimic some of the other studies that have compared vein diameters in single device use, whether it is still good to use in larger vein diameters.
So in our institution, we transitioned from laser in around 2017 to MoCA. So we really didn't do RFA, and we don't have VENOSIL. So from that reason, it's hard to compare. The numbers were not good to compare large vein to large vein. And we know from data that larger veins, some people say 7 millimeters, some people said larger than that on the terminal ablation procedures has worse outcome. We're just trying to show in this specific device, was that a difference or not?
Yes?
Hi, I'm Mandeep Juneja from New Vance Health, Connecticut. My first question was stolen by Dr. Humphreys, which is fine. You started off saying in the introduction that, higher rates of recanalization with thermal energy, and then when you're comparing it, you're still comparing it to a group that has less than 1 centimeter size, and your results are that you still have high recanalization rate with MoCA, with a diameter larger than 1 centimeter. So is the conclusion that irrespective of technology, a higher vein size over 1 centimeter predicts recanalization? Or are you saying MoCA is better than thermal energy?
So we didn't directly compare MoCA to,
Right.
So to answer your question, we are saying that at our institution and our practice, we have not had a difference in success or occlusion rate or long-term recanalization rate comparing the larger vein size to the smaller vein size with the same device.
No, we don't want to say at any point this is better than other techniques. We did not compare it to other techniques. The only thing we can say is with the small sample we have, which in a way is around 200, a little bit less than 200 patients, we did not find a statistical significant difference. At the same time, pretty likely if you have 1,000 patients, you might find a difference. So that's one of the points also of the paper at the end.
Great. Thank you.
Thanks.